I'd like to talk about meningeal carcinomatosis, which is an unusual to rare complication, but frankly one that we see a little more than we used to, I would say. There have been some studies suggesting that meningeal carcinomatosis, which is cancer cells in the cerebrospinal fluid that bathes the brain and spinal cord and is associated with a very difficult prognosis, often in the range of weeks to a few months of neurologic decline, is more commonly seen in patients with EGFR mutations. Perhaps that is because of the prolonged survival, but it may well be related to the disease. The problem is we've not had good treatments for this. And at this ASCO, we actually saw a few trials looking at novel therapies specifically for leptomeningeal carcinomatosis, including one study with Tagrisso, osimertinib, at twice the standard dose, but one that's quite tolerable. So, Janet, why don't I just start with you on your thoughts on the potential or the impact of meningeal carcinomatosis, the fear factor, and what you think of having trials presented in this now.
That's one of the biggest fears, I think, for a lot of we patients, is that it might progress to the brain, and once it becomes lepto, that we know that the odds are not good. So just seeing that there's 2 or 3 studies being presented at ASCO on this subject is very encouraging, and that there's a trial that actually seems to be having some progress is very exciting.
Great. Everett, any thoughts?
It's been really a hard entity for all of us to treat, and it may be more common. And I do think, Jack, it is related to longer survival, right?
Mm-hmm.
So the brain, the CSF, the cerebrospinal fluid are sanctuaries, as we call them, that most treatments don't go to at the right dose. So studying this is very important. Lorlatinib is an example for ALK mutations. Osimertinib may be the example for EGFR mutations. And I think those are promising drugs. We would like to see more definitive data, particularly where dosing is concerned.
So it's kind of a new problem that we're getting because people are the beneficiaries of survival going out into several years. Ram, any other thoughts?
I agree. I think as an oncologist, one of the most distressing calls you could get is a call from a radiologist saying your patient's scan shows leptomeningeal disease. And these patients don't have good treatment options besides radiation. In many instances, they already have received radiation, so there's no more room for radiation. So being able to offer one of these targeted drugs that has a higher brain penetration is very encouraging. We have some options in the ALK setting, like alectinib and ceritinib, which are effective in preventing brain progression or even managing the disease in patients with brain disease. What we saw in the abstracts presented here are some of these drugs have responses in the brain in the order of 30–40%, and will be options for our patients. In the EGFR, as Everett pointed out, Tagrisso could be an option for patients with brain metastases and leptomeningeal disease. So it is good news. It is encouraging for patients with these driver mutations. We still have a long ways to go for patients who don't have these mutations but have leptomeningeal disease. Right. So we need to be thinking about what do we do for those patients as well.
As you say, it's frustrating. Of course, it's terrifying for the patients. It's also frustrating for us, largely because we have a sense of how things are likely to go, and it's very discouraging to not have anything better to offer. So at least now that we're asking the question, it's, I hope, going to be something that we have more actual answers. Even if it's clinical trials, these are trials with some promising early results.